All right, well, let's get started. I just want to say welcome. Thank you all for being a part of AIHA Connected, the AIHA's online digital conference this past week. I'm Craig Lammert. I'm the Executive Director for the Autoimmune Hepatitis Association. I'm also an adult hepatologist at Indiana University. And I am thrilled to be able to moderate this final piece for our 2021 conference, which looks a little bit different. But joining us today too, just briefly, is Aaron Anderson, the Director of Programming and Advancement for the AIHA as well. Over the next hour of this live discussion Q&A, we are so lucky to have a few hepatologists with us. One at least an adult hepatologist, the other a pediatric hepatologist. They represent a number of academic health systems and actually span the country. We also may have another hepatologist join us later from the West Coast as well. But all three of them have dedicated focus in autoimmune liver diseases and are experts in AIH in their own right. So let me briefly introduce them. And all of them sit on our AIHA medical board. So first, I'm pleased to welcome Dr. Cara Mack. She's a professor in pediatrics and gastroenterology and hepatology and nutrition at the University of Colorado. Thanks for being with us, Dr. Mack.
Hi, everybody. Yep, thanks. Pleasure to be here.
And then next, I want to introduce Dr. David Assis. He's associate professor at Yale School of Medicine. Thanks for being with us too, Dr. Assis.
Oh, anytime. It's a pleasure. Thank you.
So we have a variety of talks and presentations this past week that's covered many topics for both adult and pediatric patients with autoimmune hepatitis. So this live Q&A program, though, was designed to give the opportunity for our members to ask questions about really any aspect of this disease. And I want to remind you that this session is being recorded. So therefore, please, if you would turn your camera or microphones off, except for our presenters, our hepatologists and moderators. But questions can be asked in the chat box function that's found on the right side of your Zoom screen. We've compiled a number of questions from our members all week with all the talks that we've had, but we've also collected other relevant questions through our social media as well as email accounts as well. I think, I want to thank Indiana University, specifically the Division of GI and Hepatology, as well as Sanguine Biomedical for their gracious support of this digital conference this year and ensuring that all of our conference material comes to you at no cost. And then finally, quickly, just a brief disclaimer, I do have to alert you the information shared in this conference presentation is not a substitute for medical advice. And in fact, we can't provide medical advice. We can only speak generally about diseases and symptoms and management. And really all your medical care and treatment should only be directed by your own doctor or healthcare professional. So with that, let's dive in. And again, it's such a benefit to have an adult hepatologist as well as a pediatric hepatologist joining us. I think this will give us a little bit of a different perspective as we ask some of these questions. And so before we get the questions going in the chat box, we have a few things that have been sent to us this week. And one thing we wanted to focus on was really environment. And this year, we really dove into the diet aspects of this disease. And in fact, that we think potentially diet could be important, not only in terms of the disease onset, but also possibly the symptom management of this as well. But we realize that there's a lot. And I would love to start, maybe Dr. Mack, if you wouldn't mind me asking, particularly in the pediatric world, we've seen some ideas of elimination diets and how these are connected to other autoimmune diseases, particularly inflammatory bowel disease. Do you think it's any possibility that diet and again, what we consume potentially could be linked to the type of inflammation that we see in autoimmune liver disease, specifically autoimmune hepatitis?
Yeah, I think the general theme as to what causes autoimmunity in general is that in the genetically predisposed individual, there is an environmental trigger that then sets off an abnormal immune response that's progressive. So that environmental trigger, the theories are, is that a virus infection? Is that an environmental toxin in the soil? So you could hypothesize that a third potential environmental trigger are certain foods that the patient doesn't necessarily agree with or is an allergic type phenomenon that starts it off, or injury. That being said, I'm not aware of any studies or literature in pediatric autoimmune hepatitis that have shown strong evidence that certain foods would actually trigger this disease. And in children, because they are growing so rapidly, especially during certain times of their childhood, we caution in trying to do food elimination and food restrictions because it really can affect their overall health and growth, especially during those critical times where they're having growth spurts. So in general, for children, we like them to have a wide variety of foods without any major restrictions. And of course, keeping it healthy so that they don't become overweight or develop fatty liver disease.
Yeah, I think those are some really excellent points. And before we step just beyond that, I want to quickly introduce Dr. Michele Tana, who's an adult hepatologist at UCSF. Thanks for joining us, Dr. Tana. I appreciate it.
Hi, Craig. Hello, everyone. Thank you so much for having me.
So Dr. Assis, again, diet, I don't know if this happens to you, but I share this often with my patients. It's usually as I'm getting up to walk out of the room, the patient who I just diagnosed with AIH after a few months of either diagnostic testing and liver biopsy say, Dr. Lammert, Dr. Assis, what should I eat now? How do you respond to that in the clinic?
Good question. Good question, Dr. Lammert. I agree with Dr. Mack that the precise link between diet and the state of the immune system and autoimmunity, at least as far as the liver is concerned, is not quite worked out. With the immediate caveat that so many patients with autoimmune liver disease also have celiac disease. And so I'm very particular about screening everyone up front for that, because we don't want to get confused about liver inflammation that's derived from gluten related autoimmunity. But that aside, I think it's always an important topic. You, Dr. Lammert, I think of as being at the forefront of a lot of the studies of the environment in autoimmune hepatitis. So I would certainly take some cues from you in what you've been working on in terms of your research. But to my knowledge, the elimination diets that have been shown for the gut, for example, for inflammatory bowel disease have shown some promise. However, it's hard to know how much of that is just cleaning up the diet versus specific individual items that are less immunogenic. But as with Dr. Mack, I don't feel that there is necessarily a strict autoimmune liver diet per se. I really focus more on healthy eating habits. Obviously, a lot of processed foods and things that might predispose to metabolic syndrome and fatty liver need to be avoided, particularly if we need to start and maintain a certain degree of steroids on board. So I always emphasize the need for a healthy diet. Obviously, for those patients who might unfortunately have more scar tissue and perhaps even being at the cirrhosis stage, I emphasize very strongly the need for protein in the diet. That's important. Chicken, eggs, fish, beans need to always be part of the regimen. But beyond that, I'm always cautious to say that this or that diet will necessarily have an impact on the hepatitis itself.
Yeah, thanks, Dr. Assis. I think that's really well said. I kind of fall in line with both of you. And again, just to highlight, Dr. Mack and Dr. Assis were on the recent guidelines from the American Association for the Study of Liver Disease. And celiac screening, as well as screening for autoimmune thyroid disease, seems to be an important approach for patients. So that can fit into that as well. I will anecdotally say I have a number of patients that will praise diet as a major modifier of their disease. Now, I can't correlate that with fibrosis or scarring, but I definitely can say that they feel better. And again, we took this another step further, and this is where I'm going to ask Dr. Tana maybe, is we had James Lewis talk this week about the utilization of Mediterranean diet and some of the data that we've seen in inflammatory bowel disease, and potentially maybe some impact on inflammatory markers, but also just quality of life. Also, inflammatory bowel disease is a little bit different, a lot of GI side effects, but we see that in our patients as well. Dr. Tana, any other thoughts or things that you tell patients to avoid or to consider in realm of diet?
Yeah, it's a really good question. It does come up a lot. I don't know that I have anything much more to add. I agree with you guys that I think it's highly plausible that diet could impact autoimmune hepatitis, because we think there is an environmental trigger, but we don't have any hard data. And I agree that, what I tell my patients is focusing on a healthy diet, avoiding the metabolic risk factors associated with fatty liver disease, which we see very frequently in our autoimmune hepatitis patients. So I don't particularly encourage the Mediterranean diet, though I know there's a lot of great data about the Mediterranean diet in other diseases, but I generally focus on a healthy diet with whole grains, lots of fruits and vegetables, lean protein, as Dr. Assis mentioned. And then again, for the cirrhotic patients, kind of avoiding sodium, high protein diet is good also. And then avoiding raw seafood, as cirrhotic patients are more susceptible to infections. But I do believe there's something in sort of the anti-inflammatory diet and different things like turmeric. I just don't think that there's strong enough data to guide us at this point.
Yeah, no, makes sense. And just a brief mention out of the dietary piece, at least nutritionally, vitamin D deficiency. I know there's been, I think, 2 papers that have looked at low vitamin D levels in terms of outcomes. I don't know how high quality the data is, but we've seen this play out in inflammatory bowel disease too. So I think, you know, I check vitamin D levels at least yearly in all my patients here in Central Indiana. Outside of that, maybe we'll just kind of shift on to one other topic that a number of you brought this up, fatty liver disease. This was also a little bit of a change in the guidelines and was a part of some of the questions we received from social media as well. Is this relevant to the AIH patients, autoimmune hepatitis and fatty liver disease? I'll throw that out there for everyone. Maybe we could take the pediatric and the adult approach.
Yeah, I think certainly Dr. Assis has a lot more experience with this because fatty liver disease, the incidence is higher in adults versus children. But we definitely see the combination. Maybe if I had to guess, 15% or so of kids will have both fatty liver and autoimmune hepatitis. And it's important to know because if we have a new diagnosis, I will try to always start with budestinide as a treatment to induce remission in the overweight or obese child who also has fatty liver. And therefore, you don't have to worry about the steroid side effects such as the weight gain, as well as prednisone can be associated with the development of fatty liver all by itself. So you don't want to add insult to injury.
And Dr. Mack, is there anything about, and I'm sorry to interrupt you, is there anything about kids that make you think fatty liver disease is different than the adult world?
Is it different? I mean, if you look histologically, it's more the location of the inflammation under the microscope. If you looked at that liver biopsy, is often different in the child compared to the adult. So the look of it under the microscope, the location of inflammation is different. But in general, there's the same progression where you go from the fatty liver to the inflammatory disease to cirrhosis.
How about the children in clinic? Do they look any different?
Sure, I'd be more worried about fatty liver disease in the overweight or obese child who may also have acanthosis, the darkening of the skin, and other signs of metabolic syndrome such as hypertension. Yep. Yeah.
Dr. Assis, how about the adult world? How do you counsel patients regarding, weight and fatty liver disease risk in your autoimmune hepatitis patients?
Yeah, it's a great question. And it's only going to become more important as time goes on. I probably would, artificially separate it into 2 conversations. One is, what is the impact of having fatty liver, active inflammation from fatty liver, and autoimmune hepatitis from the get-go, from the time of diagnosis? That is where we need a lot more studies. There was a small study from University of Vermont that suggested worse outcomes because you have 2 processes going on at once. I think that is something we need to understand better. But what I see even more commonly, though, is an unfortunate side effect from ongoing steroids or other processes is weight gain, fatty liver that comes on secondarily after a few years of treatment, in particular, perhaps in some consults where patients have been on high doses of steroids, perhaps beyond what's needed. And then I think that can become an extra problem or a new problem, perhaps, right? And when we start to see liver enzymes going up, which just happens not infrequently, and where it's not correlating with the degree of immunosuppression, I start to get a little bit concerned that now we may be dealing more with fatty liver even than the immune system. So I think, from the provider standpoint, we need to do all we can to minimize long-term and even unnecessary short-term doses of steroids while still controlling the disease. I think because inevitably, at least for now, steroids are a part of the induction of remission, we have to counsel up front, and some high blood sugar with a maybe mild case of diabetes that wasn't so bad that can become worse is one thing that we see. And so working very close with primary care is going to be important. Obviously an upfront discussion about avoiding things that can worsen fatty liver, actively trying to stay in a physical exercise program, avoiding too many carbohydrates and sugars. Those are things that we try to review up front. But I think the 2 things sometimes are different, but the metabolic complications of our treatment is something we need to be aware of too.
No, I think that's great. And maybe just to shift gears a little bit away from this, we had a talk by Vic Navarro from Einstein this past week. Really excellent talk thinking about dietary supplements. And here in Indiana, we actually just found in a cohort of online patients, actually from our autoimmune hepatitis organization, that CAM use or complementary alternative medical strategies are quite prominent in anywhere between 25–30% of patients after the diagnosis of AIH. And so surprisingly or not surprisingly, many doctors don't know that their patients utilize this. But some of the symptoms, as you would expect, would be fatigue, depression, poor sleep. But one of them, a big one, is pain. And so hearing a lot about patients complain of joint pain was a topic of question that came in through social media this week. I'll throw this out for everyone. What do you see in the clinic in terms of joint pain that you relate to autoimmune hepatitis? And when do you know or think it's a time to step a little bit further with possibly referral to with a joint expert? Any thoughts about that? Maybe Michele, that would be.
Yeah. So I think joint pains are super common amongst patients with autoimmune hepatitis. Both, I think, at the time of presentation and also during therapy. One phenomenon that we do see is that as the corticosteroids are being tapered, frequently that's when joint pains will flare. And I think that we as clinicians should just have a high level of suspicion for concomitant autoimmune diseases like lupus or rheumatoid arthritis that could cause joint pains. But yeah, that's a very common issue that we see in the clinic.
Yeah, I'll say on pediatrics end as well, joint pain is a pretty common symptom at presentation. And so I will think about sending that patient to our rheumatologist to look for juvenile inflammatory arthritis, JIA. If the pain is associated with swelling, tenderness of those joints, that would be unusual. Usually it's just pain without the swelling. So if I see that, I'll refer to rheumatology, or if that pain doesn't go away with my treatment for the autoimmune hepatitis. If that gets in remission, yet the joint pains are persisting, I'll get a second opinion from our rheumatologist.
And that's exactly what Lori just chimed in here, and actually was the focus of another question that a patient said, my hepatologist thinks I'm crazy. I've been in remission for 4 years off prednisone for the same duration, but my joint pain is so severe, I cry often and can't sleep. So just the reiteration that, yeah, joint pain can come in biochemical remission, and those may be good indications that maybe getting extra help. Now, what I'll flip on to our adult hepatologist is how helpful is rheumatology in terms of therapies? And once the patient comes back from rheumatology, how do you counsel them, or other strategies to help with pain control?
Good question, because this does come up in a certain frequency, as you mentioned. And just to reiterate what Dr. Mack and Tana said, the joint pains are disproportionate and not improving, especially as you respond from a liver standpoint. I think it's important to get rheumatologists involved. I think, lads, with many things in life, having a rheumatology colleague for whom you can have a certain understanding as to what you're dealing with if you have two conditions is very important, so that the patient can be at the center and we're all trying to help in a coordinated manner. If a new diagnosis is made and now we're dealing with autoimmune hepatitis and, I don't know, rheumatoid arthritis, psoriatic arthritis, or lupus, I think the most important thing is a lot of communication to see what's the single best regimen that will get the job done with both conditions. We certainly don't want to overtreat or treat with medications that may not attack both problems. So I think anytime there's a rheumatologic diagnosis in a patient with existing or newly diagnosed autoimmune hepatitis, it's individual at that level, of course, but it has to be highly coordinated. And it's often very successful.
Yeah, so, and if you go back to the original stem of the question, I brought up the idea of CAM. And so the direction we're going is, when all else fails, patients are seeking other strategies. And one of the most important ones we see patients turn to because of what is kind of hot in media and available locally is cannabinol, or CBD. Now, these come in a variety of products, dosage, lozenges, serums, pills, all types of stuff. I'd be interested in both the adult and pediatric input on how do you counsel patients regarding CBD? Any takers? Maybe Dr. Mack, from a pediatric perspective, does this come up? Do parents utilize CBD with their kids?
No, I think I've only been asked that question a couple times. So, yeah, so I think I should probably defer to.
Okay, fair enough.
I mean, I guess I can comment since I'm in California, where cannabis is legalized. You know, we see cannabis used pretty frequently. I have to say, like in my autoimmune hepatitis and other patients with liver disease, I generally discourage them from using CAM. I think it, in large part, based on some of the data that Vic Navarro has published, and just to sort of eliminate some of that diagnostic confusion that can arise in our autoimmune hepatitis patients. So just as fatty liver disease can, cause some confusion about what's going on in an AIH patient, so can drug-induced liver injury or hepatotoxicity. So I definitely want to hear from Dr. Assis, but I'm also curious, Craig, like what Vic Navarro had to say when he talked to you guys.
Yeah, just before Dr. Assis goes, I'll tell you, Dr. Navarro avoided the CBD talk and topic. And in fact, as you know, there really isn't much out there for CBD and AIH. We published something about a year and a half ago, looking again at this group. And it seemed like it was well tolerated, but again, it's a very specialized focus group. And patients actually saw significant benefits. Now, the doses were widely variable. And I think probably one of the most important pieces is the dose ranges. In fact, with Apodolux, which is the synthetic form of cannabinol that is now utilized for a few different pediatric seizure disorders, we have seen some liver damage or injury related to this in rare instances. So I think what does it look like is there's probably a dose effect. Again, I don't know if you guys say the same thing. I often can get in the way of patients trying something that they really want to. But of the patients that have utilized it, some have seen benefit. And in fact, with our CAM study, we actually found that patients were able to find something that was beneficial to treat one of their side effects of this disease. Now, that includes everything from CBD, but also meditation, better eating, diet. So there are strategies to evolve. Dr. Assis, anything else about CBD?
Not about CBD per se, but first of all, I would say I'm glad you had Dr. Navarro on. He's trained me actually, and so he's somebody who I'm always indebted to, and who really has, an extensive knowledge of CAM, as you all know at this point. Second, when it comes to joint pains, I think it was already mentioned before, I would always start from the presumption, have we ruled out a rheumatologic disorder? And until that's done, perhaps to satisfaction, I would hesitate to go straight toward some alternative therapy. Perhaps there's an underlying diagnosis that needs to be explored. But if that's not the case, and if the hepatitis is otherwise in good control, then it becomes the gray zone, right? Which is what you're talking about. I mean, from a very practical standpoint, no matter what the CAM, I always start from the presumption that, let's first do no harm. If there's a chance for toxicity, whether it's hepatic or anything else, that may not be worth it. And in individual conversations in which a patient is very interested in trying something, I'm somewhat open to that. If I don't see signs of harm, maybe monitoring enzymes more frequently. I also mentioned that due to lack of extensive data for any of these things, I wouldn't go out and spend $1 million on something, but I know that quality of life is important. So I'd really try to individualize it at that point.
I think that's great. So we have a lot of questions about COVID coming in. We're going to probably save the last 15 minutes to direct our approach on COVID, as many people have that on their mind. We're going to transition just a little bit into therapy and treatment, because that also is coming up as well. I think the big question that we came in all week, and it was mentioned briefly, but really no examination of the data, and we don't have to go into the details of it, but what is the possibility of getting patients off of medication? We have some now guidelines. Historically, this used to be more par for the course after therapy and removal of everyone. However, we learned that this was the hard way, that many, depending on what study, anywhere from 50 to 100% of patients relapsed. And that would be going from normal liver tests to abnormal liver tests after withdrawal therapy. So now with Dr. Mack as lead author on the guidelines, you brought up the idea of withdrawal and also the consideration of liver biopsy, whether it was necessary or not. Any thoughts about it from again, pediatric or maybe even an adult world, since you do probably know the literature pretty well?
Right. Oh, yeah, absolutely. And then I'll give you our pediatric perspective, which is a little bit different, I think, than the adult perspective. But absolutely, if we have a child who is in remission for approximately 2 years with normal liver tests, usually on single therapy with just azathioprine, we will recommend a repeat liver biopsy. And if you have no inflammation on that biopsy, we will try and take them off the azathioprine. It works when you get that biopsy with zero inflammation. It works up to 40% of the time in pediatrics. And the reason it's so important in pediatrics to do this, to try and get them off, is because these are young children. And if we don't try to do immune withdrawal, you're setting them up for potentially an entire lifetime of immune suppression when they may not have needed it. And we even, after 2 years, if there's still a little inflammation and we keep them on it, we'll reassess 2 years later, repeat that liver biopsy and see if we couldn't get them off at 2 years, can we get them off at 4? Usually at that point, if there's still inflammation, we don't continue to try. We keep them on the therapy until they get into adulthood. But we still strongly encourage a liver biopsy prior to immunotherapy withdrawal. All the studies in pediatrics that predict the ability to stay off and not relapse, they're based on what that biopsy is showing. And I've seen plenty of times where your liver tests are normal, your IgG is normal, but under the microscope, you've still got inflammation. So
And Dr. Mack,
yeah.
could I stop you there? Because that's a really good point, because this happens to me. So
Yeah.
if you do a liver biopsy and everything looks pristine, but I find inflammation, what do you do? Do you escalate therapy or do you maintain?
Oh, well, honestly, and that's kind of a softer recommendation, right? Based on what you're seeing under the microscope. But if I see, if I'm surprised about the amount of inflammation I see, I'll actually go up on the azathioprine,
Yeah.
even if there's normal liver tests, because you don't have it under good control. Yeah.
Yeah. Great point. Sorry to interrupt you, but I thought that was worthwhile
No,
mentioning.
that's fine. That's my thoughts on it.
And from the adult perspective, Dr. Tana or Assis, any thoughts about adults coming off therapy and how you're counseling them these days with the new guidelines?
Well, I think there has been interesting data from Europe, mostly saying that relapse is universal after withdrawal. And so I have typically strongly encouraged a repeat biopsy prior to attempt of withdrawal. But with the recent guidelines, I don't think it's absolutely 100% necessary. So again, it's very individualized. And I've also had that experience where I've been surprised by the amount of inflammation on the biopsy, despite 2 years of biochemical remission. And so I have tried to escalate immunosuppression at that point.
Yeah. Yeah. Anything else, Dr. Assis?
Yeah, it's always a very important topic. First, I would say that hopefully we can get the patient off steroids, if at all possible, prior to even having that conversation, because I think that's first and foremost what we need to try whenever possible. Second, there was a study from 2016 showing that patients who relapsed had a higher ALT than those who didn't, but all those ALTs were within normal limits. And the range of those who had a relapse was 17 to 34 units per liter, whereas those who remained in remission were in that 8 to 15 range. So even within normal ALT, sometimes we can read between the lines a little bit who might be at higher risk. And then honestly, I have a conversation with my patients, say, do you really want to go through another biopsy? And they say, I would absolutely not want to go through a biopsy. Well, okay, well then perhaps we should either take a chance, but with very close monitoring, or maybe just keep a low, well-tolerated dose of a non-steroid regimen, Two things I should say though, just briefly. One, I would say if you presented with severe jaundice and you had an acute presentation of autoimmune hepatitis, I think it's a high risk setting to withdrawal. And then I counsel against that. I just try to find the lowest well-tolerated regimen, but I don't attempt to withdraw for severe presentations, even years later. Second thing is, I'm sure, Dr. Lammert, in your group, I think we all need to make it clear to our patients and family members that I don't think any of us feel that our current regimens and treatment options for autoimmune hepatitis are good enough. So it's not good enough. It's not good enough to rely on steroids, azathioprine, risk of relapse. And so I think we all need to really push ourselves, push the field, push pharma, to find better options for this, because I don't consider the status quo to be satisfactory 10, 15 years from now.
Yeah, I agree, Dr. Season. You're definitely preaching to the choir here. And again, one of the parts that we really want to advocate is better, more targeted therapies with less side effects. I think this is important. And on that note, too, a point came in about acute severe presentation with autoimmune hepatitis this past week, and really understanding two things. One is transplant, where I'm heading, and two are steroids. Why are steroids so necessary? Maybe we'll attack the steroids piece first. So what is it about steroids that, and why do we need them? These drugs have been associated with such significant side effects, and now we have another option, budestinide. Why do we still rely so heavily on them? Maybe Dr. Assis, just based on your understanding of immunology, any comment on steroid use?
Yeah, well, the very initial case series of autoimmune hepatitis in early 50s, before availability of steroids, showed a pretty dismal prognosis for autoimmune hepatitis, 60-70% mortality at 3 to 5 years. And so fortunately, we're not dealing with that kind of situation. And I think for better or for worse, at least in the short term, initial treatment, especially for very acute presentations with steroids, there just may not be an easy substitute for that in the immediate future. It has the real advantage of calming down the immune system, making lymphocytes demarginate, and can really help to put out that initial fire. That's the way I think about it. Treating with higher steroids than necessary may not be helpful, but there are times it really is necessary. So I think there is a role for that. And you often see that also in lupus and other conditions where you have to treat immediately for a flare. I think it's what we do after that initial fire is starting to come down that may make a difference in terms of how much steroids need to remain on board, because that's when I think the cumulative toxicity starts to build up.
Yeah, no, I think that's good. There's still a big role for steroids, right? So hopefully with therapy changes, maybe we can target steroid-free regimens even up front. Again, I don't think it's so crazy to think that we can move that direction. Again, just for the benefit of time, we probably go a little bit faster through some of these as well. One of the big questions we get from our members often is about the role of repeat liver biopsy. Again, from the pediatric world and adult world, do we need these follow-up biopsies? Is there a set regimen, or how do you decide whether a biopsy is needed?
So I mentioned our standard of care for biopsying related to anticipating withdrawal of immune suppression. But the other time we'll do a biopsy is if our patient is only a partial responder, where we've got them on fairly high dose steroids and azathioprine or Cellcept, and we're still not getting those liver tests normal. We'll take a second look to see really what's going on in there, because sometimes your biochemical or laboratory data lags behind what you see under the microscope, that things may actually not look so bad under the microscope, but the liver tests just haven't responded to where they will eventually be. So those are the two most common reasons why we would biopsy. Dr.
Tana?
I would agree. I think it's pretty similar in the adult world for adult patients with AIH, that there often is a role for a second liver biopsy. It's not needed for everybody, particularly if they have complete biochemical remission and are not interested in coming off their immunotherapy. But certainly there's a large role for a liver biopsy prior to attempt at treatment withdrawal. And then also when there's diagnostic uncertainty about the cause of elevated enzymes, oftentimes the biopsy will reveal metabolic associated fatty liver disease, or even an overlap syndrome, or just poorly controlled AIH.
Yeah, no, excellent. And I'm sorry, let's move on from that. Again, maybe Dr. Assis can tell us, this idea of utilizing first and second line agents, which actually a lot of our members understand the terminology, but first line typically being azathioprine plus, prednisone, budesonide plus minus azathioprine. Second line thinking Cellcept and maybe others. Where do we go? And this is in our box here about treatment failure with azathioprine and second line agents such as Cellcept. Dr. Assis, what's an approach you take with your patients? Good question.
Most patients will respond to first-line agents, especially if they're titrated, as best possible. It's always very personalized at this level, so it's very hard to generalize. But I think we can expect to ultimately achieve remission, hopefully in 6 to 12 months, no later than that, with first-line regimens. There's some patients who don't tolerate azathioprine because of immediate nausea and vomiting. Then I am quick to reach for an alternative, typically Cellcept or MMF. But there's a subsegment of patients who just don't respond to, even more steroids than I'd like to see on board in addition to azathioprine. I will be very honest, it's something that I haven't historically done, but I'm starting to do a little bit more is adjustment of azathioprine based on metabolites. There's an article in Press Now in Hepatology that suggests that you can really get the most out of that. And so I hope to even improve my own practice by adjusting a little bit. But even despite that, I feel there will be a subsegment who just don't respond. Again, I don't want to get too anecdotal, but
Sure.
Generally speaking, I don't feel that if you've failed optimization of azathioprine, that CellCept will necessarily be helpful. I tend to reach more for calcium inhibitors these days, such as tacrolimus. And then very lastly, this is beyond what you're asking, of course, but patients who aren't responding to anything, I do think there's a role for B-cell therapies. We just don't have the right therapies, or we have one that's very harsh, I would say rituximab, but I don't go to that very often unless I'm really desperate.
Yeah. And so you alluded to this earlier and actually brought up this theme again. What is the treatment goal, Dr. Assis? What are you targeting and how low?
Yeah, it's a biochemical response, which would be a normal ALT. To be quite honest, for a young, otherwise healthy person, it should be less than 20, the ALT, and a normal IgG, assuming the IgG was elevated prior to diagnosis. If you see that, that actually is a good sign. There's an article out just in the last year showing that perhaps how fast you get into that normal range can also be helpful. So maybe if your AST and ALT goes down by 80% at 2 months, that's a good sign. So it's something we look for, obviously without giving unnecessary steroids, but at least looking for that response. So I'd say that by 6 months, 12 months for sure, you need a normal ALT and a normal IgG. If that's not starting to happen, then you need to start adjusting and thinking about alternatives.
Yeah, thank you. That's excellent. And then maybe Dr. Tana and Dr. Mack, budesonide is brought up often in our groups. I'm still surprised. And again, it depends on the clinical situation. That's what I'm going to ask about is some hepatologists or gastroenterologists are not using budesonide still, despite maybe just mildly elevated liver tests. What are you looking at for patients specifically when you decide to use budesonide versus prednisone? When is it safe? When is it feasible?
So I do really like budesonide, and I try to use it whenever possible to avoid the systemic side effects of prednisone or even prednisolone. We do not use budesonide in patients with cirrhosis because of a risk of thromboembolism and thrombotic events. I guess one concern with budesonide is that some hepatologists feel like it can be harder to wean, or maybe patients end up staying on budesonide longer. But again, I think it's still a safer alternative than long-term prednisone use. Another limitation of budesonide is cost, and sometimes it's difficult to obtain with insurance issues. So sometimes when we, again, like Dr. Assis was saying, want to put out the fire fast and really get control of inflammation, we go to prednisone. It's tried and true. We have longstanding experience with it, and it's effective in most cases.
Mm-hmm. And I agree with all that. I'll add from a pediatric perspective, we are making a conscious effort more and more to use budesonide over prednisone. Early on, we always went to it if possible. If you didn't have cirrhosis and it wasn't an acute severe presentation, those would be 2 reasons not to use budesonide. But we would actually look to budesonide in our obese patients, our patients with significant mental health issues such as depression, and then some of our teens with severe acne, because we know in all those conditions, prednisone is just going to worsen those. But more and more, the pediatrics team is definitely looking at budesonide and using it much more.
Yeah. And again, in the world of therapy and then also subsequent follow-up, our patients are highly motivated. They track their own labs. I'm sure you see them in your clinics. There's also sharing of what their doctors do in terms of routine labs. Dr. Assis, any kind of guidance for when we should get follow-up labs? Is there any kind of guidelines that tell us there's a certain time frame to be following?
Yeah, it's a good question. It all depends on what's going on. In the very beginning, especially for an acute case, depends how severe we're talking, but somebody with very elevated liver enzymes might even need it twice a week. But ordinarily, when starting therapy for somebody who has a very active hepatitis, probably weekly and then every 2 weeks. If we're talking more long-term monitoring, usually every 1 month to 2 months if we're still monitoring closely as we're tapering medications, and I go down all the way to every 3 to 4 months if somebody's very, very stable for a number of years. So I think it's all context dependent.
Yeah, any different realm in the pediatric world, Dr. Mack? I got to be honest, I don't know what the approach is and if it's different.
It is not different. It's exactly the same. And Dr. Assis created a beautiful flow chart in the guidelines to guide the practitioner as to the frequency of obtaining labs, depending on where they're at in their disease process.
Wonderful. Yeah, so we will share, actually there's a patient-friendly aspect that was written to go along with your guidelines, which we have shared this past week and we'll share it again. I don't know if that guideline includes the lab management, but again, it's all dependent on the hepatologist and, as Dr. Assis said, what's going on. So it can be as tight as a few days to every 3 to 6 months potentially as well. I think for the last 15 minutes or so, we're going to shift into a big topic, and that's in the realm of the pandemic. And this has been a hot topic in my office, has been a hot topic online with patients because of some of the fear that still exists with this pandemic. As we are getting more and more data, particularly out of transplant patients that have been immunosuppressed, also just to speak globally about the vaccine and COVID, we're going to ask about the vaccine, but also the infection itself. So first things first, if any of you would like to chime in, is the vaccine safe for patients in autoimmune hepatitis on chronic immunosuppression? And how would you counsel your patients if they were on the fence?
Yeah, it's a good question. I know, Dr. Lammert, you might be a scholar in the sayings of Yogi Berra, who said, that predictions are difficult, especially about the future. So with that caveat, I think that I take a practical approach with the patient and say, listen, a bad case of COVID is life-threatening, and even more so if you already have cirrhosis. So I think you really don't want to get a bad case of COVID. I know we're learning about the vaccine, and there's nobody out there can tell us a 5-year, 10-year expectations. But I advise that given what I've seen so far, it is safe to get the vaccination. I think it's hard to predict how long the immunity may last, but I've had several patients who are on immunosuppression and had a significant robust spike protein measurement, which is something else we could talk about.
I'm gonna stop you there, Dr. Assis, because that's going to be the follow-up.
All right.
Dr. Tana, do you recommend the same thing to your patients?
Yes, I have.
For vaccination?
I have been recommending the vaccination to my patients because our autoimmune hepatitis patients are immunosuppressed, and we've already seen a number of cases in autoimmune hepatitis, COVID cases in AIH patients. So I do think that the vaccination makes sense, though, I recognize that there's not a great deal of data in this specific population. But overall, I think it does make sense, and you don't want to get COVID.
Yeah. And Dr. Mack, because there's been some now reports of inflammation within the heart, particularly it seems to be more in males and maybe a little bit later into teens and early 20s. Any change in, again, the vaccines are only available down to the age of 12 in the pediatric populations. How are you counseling patients?
Right, but we very similar to the adults, where we are recommending the vaccine once they hit the age of 12, with the exception of the newly diagnosed autoimmune hepatitis patient who may be on very high dose prednisone. The odds are they're not going to have a good immune response to the vaccine, so we would try and taper down on that prednisone. But we're learning a lot from the inflammatory bowel disease group, and even being on much more potent immune suppression, they actually are finding that some immune suppression might be somewhat protective from a severe COVID case, because the part of the COVID disease is the inflammatory response. So just kind of another reason that you can rest a little bit easier, even if you're on some strong immune suppressant, it may actually help protect from a severe case of COVID.
Yeah, I think that's an excellent point. That's exactly what we've seen from at least the limited studies that have been out, not only just AIH, but now we see more data from other immunosuppressed diseases as well. This idea that immunosuppression may worsen outcomes is really just not true from what we see, generally speaking. But I think Dr. Tana said it well, is that there are other risk factors that our patients have. So cirrhosis increases the risk of a severe COVID case and or death quite substantially. And the other things still stand true. Hypertension, cardiovascular disease, male status are all relevant pieces. But shifting more over to the vaccine, so we know that we want to try to protect our patients. And I'm not exactly sure how everyone's been following the data, but Dr. Assis alluded to this idea that the spike protein and the formation of an antibody after vaccination may be suppressed in some patients on immunosuppression. What are you telling patients about this, and what strategies are you taking to look into it?
Well, first thing I tell them is that I'm not an expert in that topic.
Sure, that's okay.
Because I think it's hard for us to predict. I know that you alluded a little bit to some transplant literature where not all the patients who were on heavy duty immunosuppression for rejection did show an immune response. And so I think that's important to keep in mind. But what do I say? I talk to the patient and say, listen, I don't think we know how long the immunization effect might last. If we want to see whether there is a response, I'm happy to order an antibody, look for that spike protein, with the caveats that if we don't find it, or if it's in that middle range or whatever range we think of right now, I don't have a perfect tools to interpret it. I think I just am guided by the light that, frankly, I think you are getting some protection from the vaccine if you receive it. What degree, more or less, based on immunosuppression is something that we will all learn, but I will take any protection as opposed to none. And in patients who really want to know, and I'm obviously I might feel the same myself in those shoes, I don't have problems ordering that protein, with the heavy caveat that how we interpret it may be less clear than we desire.
Yeah, just to follow a few things that Dr. Assis has said, again, with vaccination, at least in the early transplant patient data, and these are fewer patients, but a lot of it coming out of Hopkins, that we're seeing blunted responses. Now, that could be never response after 2 doses of Moderna or Pfizer vaccines, to low dose response, again, indeterminate, which again, the range can be variable, to a very high robust response, which is similar to otherwise patients not on immunosuppressants. In some of this follow-up data, the idea of using now a 3rd dose or a booster dose to rescue patients with low response antibodies or no response antibodies shows some efficacy. But again, this has been in just a very small amount of patients. Dr. Mack, any input from the pediatric perspective? Have you considered checking spike protein? And is this important in the pediatric group?
Yeah, I agree with everything Dr. Assis said, and our parents rarely ask, honestly, for the antibody to be tested to look for a good protection. But the other thing I'll bring up is that, you know, we, as Dr. Assis alluded to, we really don't know the long-term protection from the vaccine. We're measuring the antibody, but there's also likely a strong memory T cell response that would protect that patient if they were exposed to COVID. And that's something that currently is not really being measured as another response to the vaccine, but is actually very protective against infection.
Dr. Tana, any other input? And maybe I could also guide you. This has been a scenario that's happened in my clinic. We have a low spike protein, again, low being whatever the scale that was used, or a negative response. And your patients ask you, should I get a booster now? And can I?
Good question. I think that I don't have experience with that particular scenario, but I think it's a good idea, especially, I mean, it's a good thought, and it's an interesting question in light of the recent New England Journal paper. But yeah, I think I'm still mostly, encouraging my patients to get the first couple of shots. And I think it's maybe too early, unless you've seen data about the boosters, to make recommendations on that front.
Yeah, I think it was just in 30 patients that, in fact, of those that don't have any response, we can rescue maybe a third of them. But again, we're looking at a group of 30 people. Mm-hmm. So I think I'll just share my own clinical experience, which is still as limited, much like all of you have said. We don't know what to do. And again, I think hopefully data will come quickly that will help guide and provide us some lineage. And I think knowing what patients are negative may be able to at least identify those that should be first in line or seeking those pieces. The other things that we don't have data on, which I think patients also have come in tune with very quickly as well, is this may actually change my behavior for the pandemic. And one of the things that we haven't brought up is this idea of the Delta variant that seems to be more transmissible, probably not as deadly, but protected against the vaccinated populations as well. So I think ultimately, where do we go? And I think being clear with patients and realizing that this may be a changing piece, but I will also say I've had patients that still go and figure out a way to do the booster on their own because they are well educated and hungry to see if they can respond. How would you, again, now that the pandemic is still ongoing and we may still see some spike action from Delta, we'll see. How are you counseling patients out in the community and maybe from a pediatric and adult perspective?
I'll just say quick from peds because it's not, it's a much larger issue in the adults, but our children suffered from having to be at home for an entire year from school. It really had an impact on their psychosocial health. So we are big proponents in pediatrics of getting those kids back to school, doing whatever, depending on the situation, if they need to have the masks and of course the hand washing. But we want the children back out into society because of all the negative effects from being isolated for so long.
Dr. Assis?
Yeah, I would agree completely. And even in adult populations, I don't believe I've counseled an individual patient thus far, now in the era of vaccinations, of course, that the autoimmune hepatitis could or needs to be viewed as life restricting, to be quite honest. So I think that one can live their life with the precautions that we're all learning about. As always, hopefully it wouldn't take COVID pandemic to remind us to use the least amount of effective medication, because that will always be useful to control the disease. But no, I think we need to get back to life in a safe way. But yeah, I don't have any additional precautions that I'm fearful on for autoimmune hepatitis beyond what we've already discussed.
Sure. And in line with vaccination, and Dr. Tana, if you're interested, but also maybe Dr. Mack, given the pediatric group, we get questions about vaccinations often. And again, particularly with response now with immunosuppression and kind of how robust that response is, but also then balancing this idea of live versus inactivated vaccines. How do we guide patients? What should we be telling them? And because it seems also a lot of the primary care doctors, despite many of them are really good, a lot of them defer a lot of these questions to us as well.
That's a great question. I mean, I guess what I've seen most patients get is the mRNA virus vaccine. So I think that's my go-to, but I'm not familiar with any data about the live.
Maybe I'll reframe it. And I'm speaking about vaccines altogether, I guess, in a little bit of a shift, particularly related to flu vaccine, but also the MMR and maybe, again, previously utilized inactivated viruses. How do you counsel patients regarding that around immunosuppression?
Yeah, I can speak from a pediatric perspective since that's the age group that is receiving most of the vaccines in general, right? Live or attenuated. And if someone is on triple immune suppressive therapy, such as prednisone, Cellcept, and tacrolimus, we would hold on live vaccines. And but you can consider an attenuated or killed virus vaccine. But again, the more immune suppression you're on, the less chance your immune system is going to produce a protective response. So you just have to weigh the benefits and risks. The other thing is, and it's in our guidelines, there are clear guidelines as to when to give vaccines based on the different scenarios of immune suppression through the CDC. And so I always counsel practitioners to go into the CDC and look at the latest recommendations based on the specific vaccine that they want to give and compare that to the amount of immune suppression that the patient is on. So one more comment regarding live vaccines, in children such as MMR, chickenpox vaccine, the most experience we have with that is in the post-transplant setting where we have not been giving it early on because of all the immune suppression, but once they're down to single therapy such as tacrolimus, we will consider giving the live vaccines and we get a good response. So in general, vaccines are good. You just have to weigh the risk benefit depending on how much immune suppression you're on.
Right. And Dr. Tana, there was a question here about hepatitis A and hepatitis B vaccines. safe for our adult patients that don't have antibodies that are on immunosuppression?
Definitely, that's a very clear recommendation that AIH patients should be vaccinated for both Hep A and Hep B. Yep.
Wonderful. Just briefly, I'm going to go back through the boxes. We're in the last 3 or 4 minutes here and make sure that we've kind of cleaned up. There was a question about environment. There was some discussion about coffee. I think that was something I shared again from our research group. Historically, we saw some coffee differences in 2 other autoimmune liver diseases, PSC and PBC. But at least our group at Indiana showed that coffee drinking was less in AIH patients as well. I think the question is, if I don't drink it, should I be drinking it? I don't know the answer to that. This is a pure association study. We didn't see any outcome differences for patients that were transplanted versus not in their coffee drinking status in about 350 patients or so. But I will say, coffee has been in the hepatology world for the past 30 years or so, when we learned that coffee drinkers that also abused alcohol seem to do better as well. So coffee's been shown to blunt an animal model, at least of fibrosis. I encourage coffee drinking, but also for the benefit out of a New England Journal of Medicine article from about 5 or 6 years ago that showed reduce all-cause mortality when you drink anywhere from 3 to 6 cups per day, and it doesn't matter caffeine status. So I'm a proponent, but if you don't like it, that's okay. And I'll just pause here for a second and I'll ask our presenters, are there any other key points that maybe you've heard recently or discussed with other patients that are relevant to our members as well? And if not, that's okay.
Oh, I'll just say one thing. I think that in the future, we don't really have, at least in pediatrics, we don't have a lot of data regarding quality of life, the impact that this disease is having on children. So I think there's probably a little bit more of that in adults, but I'd love to hear from David and Dr. Tana. So that is an area of research that I think through this organization, we could create some studies to really help answer the question, what is the impact we're having with this disease on children?
I totally agree. I think that's a clear unmet need. I was struck by an article from the UK a few years ago, 2-3 years ago, where quality of life impairment existed in autoimmune hepatitis, which perhaps I could have anticipated, but it was irrespective of the actual dose of steroids. So it tells me that as much as we'd like to say, even that some of the medications are directly responsible for side effects, which they often are, but there's a more general impairment of quality of life. And I think that is an unmet need, similar to other autoimmune diseases where we can control the inflammation, but the overall fatigue and quality of life is not as good. Our group here has done a pilot study recently of mindfulness and looking at the impact of that on quality of life and disease activity even. And so I think we need to be creative, but really push for that. And I think this is where an organization like this could really be at the forefront.
Yeah, and I'll just echo that quality of life is a huge knowledge gap and area that needs more research in autoimmune hepatitis. And yeah, I would just sort of applaud everybody who's involved in the Autoimmune Hepatitis Association for being active and helping to advance that agenda. And I think that a lot of great research and better knowledge can come out of these types of collaborations.
Oh, that's great. And thank you all. And I just will say from the quality of life perspective, and I'm going to put on my executive director hat, this is the common complaint. And this is what you hear in clinic. Patients are still suffering from this disease, and there's very few that actually feel normal. So as an organization, we do want to target this. And much like Dr. Assis said, prednisone has been independent of these findings. But also there's been a few other studies from Europe, but also Northern Europe as well, that's looked at this question outside of prednisone, but disease duration may be important. Fibrosis level may be important. Gender has been shown to be important independently. And actually in an abstract we just submitted, we saw that maybe weight is also an important aspect of this as well. So in the realm of the increasing obesity pandemic as well, this may be modifiable factors. So targeting modifiable factors. I think one of the challenges is in our clinic, we have little time and sometimes little expertise to counsel regarding attributes that may impact quality of life. That includes depression, anxiety, poor sleep, as well as pain. And we talked about a few of these topics today. So I think it is very rich. We have options and abilities to study this. And actually, we've already done this with a focus group of 30 patients that we've shared with our medical board that we're trying to get published right now. And I think we want to focus in, particularly in the pediatric world, but also in other high-risk groups. And again, I would say people of color and underserved populations are also ripe to better understand, to help bridge those gaps. So with that, let me say thank you all for joining us today. This was a unique and again, very candid discussion among hepatologists. As you know, we don't always know all the answers, but I think it's fun to hear how hepatologists think, and also in the realm of when we don't have the data. And I also want to thank you for participating this week in the 2021 online conference. I want to remind you, please check out our new giving program. It's called the AIHA Ambassadors. We launched it this week, and you can find more information on our website. We are a nonprofit, and thus this is all possible, but only with the support of our members, as well as our medical board and our governing board as well. And then finally, you've realized there's still so much to learn about AIH, and with collaborative responses, much like we've seen here of doctors, researchers, but most importantly, patients, we can close the areas of the unknown in this disease. So thank you again for joining us. I appreciate it.